Okay, everyone, we are going to begin now with our second panel of Straight Talk. So if you would please take your seat, and we'll have another opportunity for interaction with colleagues and friends between this panel and the next one. But for now, we want to give adequate time to the sensational panel members coming up. We're going to continue us on the theme of straight talk, of identifying not just what the problems are, but what the solutions are and whose responsibility it is to take the lead in following them through those solutions. So to moderate this panel, our second panel, we have Michelle Miller, who is with CBS as a correspondent and fill-in anchor. Michelle's work has earned her the Edward R. Murrow Award and the National Association of Black Journalists Award of Excellence. And she has served in her volunteer time on the March of Dimes National Communications Advisory Council. Highly respected and a great honor for us today, Michelle Miller. Thank you. Michelle. If we could have our other panelists please join her up here.
Turned on.
I have them put it in a rather, it's on. Here we go. There we are. Yes, I'm a journalist. Yes, I am. A broadcast journalist. So let me introduce you to this fine gathering of people here. To the far left is Mr. Jay Gershon. He is president of Northeast Ohio Medical University. To his right, Ms. Lisa Simpson, president and CEO of Academy Health. Dr. Fody Panagakos, global director, scientific affairs at Colgate-Palmolive. Next to him, Patrick Conway, a doctor as well, acting director, Center for Medicare and Medicaid Innovation. And to my immediate left, Tom Frieden, the man in charge, the director of the CDC. Thank them all for being here. So I like to think of myself as a journalist here to talk about public health, but I also think of myself in that role because I am perfectly situated as the daughter of a surgeon and the wife of a former mayor. So I feel sort of wedged neatly in between here. So I want to talk first about, and we're talking straight, right? Because the first email I got this morning sort of put me dead on here with what we are discussing. From the lower 9th Ward of New Orleans, where I used to live, and you can't get much straighter than this. Getting real about Medicaid funding. It's our turn to talk about it. That was the heading that I woke up to this morning. And so we're talking here not just about innovation in the lab. We're talking about how do you get people interested in public health as a whole. And according to you, Dr. Frieden, we're getting a bad rap globally. In fact, you've said to the National Press Club just a few days ago, and I quote, "There may be a misconception that public health is no longer needed because we have expansion of healthcare access." Well, you turn out to say public health is not healthcare for poor people. Public health is healthcare and health for everyone. Globally, there's perhaps a concern that we've crested in global commitment to public health. So for all of these reasons, there is in some quarters a sense that public health is less and less relevant. What's the problem? Why the disconnect?
I think the challenge that we have in public health is the challenge of making things visible. Often when there's progress, we don't recognize what the progress is because we don't have the illnesses, the injuries, disabilities, and deaths. In addition, there may be large problems happening today that we either have gotten so used to we don't recognize, and I would put the massive number of heart attacks and strokes that are preventable in that category, or there are problems that are happening that we're not recognizing because we're not unleashing every technology that we could that would make a real difference in finding it. And I would put in that category unleashing the microbial genome to try to better understand how organisms are spreading, whether they're resistant, whether they're clustered, whether they're virulent, and how to counteract them and prevent them most effectively. So I think the crux of the problem with public health is making visible that which might not easily be seen otherwise.
So who is not seeing it? I mean, we face like crises every single day in the realm of public health, public advocacy for health. I mean, why aren't we seeing it? I mean, is it members of my colleagues in the media? I mean, should we be put to task? Who is it to blame?
Well, I don't think anyone's to blame. I think it's better to think about how can we make more and more progress making clear why it's so important that we invest in prevention, why it's so important that we invest in prevention research, and the enormous benefits that we have gotten from that, from everything from vaccines, which NIH has been very important in developing, to new diagnostics that we and FDA and others have had a role in bringing to the market, to new ways to implement programs working with healthcare providers, with state and local governments, and emphasizing and showing that this is truly the best buy in the healthcare system, that we have a great return on investment. And that return on investment is in terms of fewer illnesses, fewer deaths, a decrease in healthcare-associated infections, which we're already seeing a payoff from economically and ultimately, and most importantly as a physician, I would say, a payoff in terms of better health and longer, more productive lives.
Dr. Foti, if you could, is it essentially a situation where you have people who don't understand the process?
I think that could be part of it. I think there's a bigger issue, though, relative to why we're seeing what we're seeing today, whether it's on the medical side or for myself personally on the dental side. And that's the fact that support is not being provided to those that need it the most. And so what are they doing? They're going to where the care can be given in the most urgent manner, which is usually the emergency room. So they're not accessing some of the public health opportunities because maybe they're not aware of them. And just recently there was a publication that came out in the Journal of Endodontics, and that's, for those of you who don't know, root canal, so I apologize while you're eating your lunch that I bring up such a pleasant experience. But they did a retrospective analysis of data from 2000 to 2008 and looked at people who came into the hospital and got admitted for a dental abscess. And during that time period, there was almost 62,000 admittances. Almost all of them were through the emergency room. And during that same time period, about 65 people died because of that complication. Now, root canals, although we don't like to think about them, are not a very expensive dental procedure if you have an abscess. But even taking it before that, why did they even have the abscess in the first place? Why aren't we doing the things that we should from a preventative standpoint, from a public health standpoint, to actually prevent these very treatable, very preventable diseases to begin with?
Well, it was interesting because not too long ago I did a story as we were focusing on universal health care and whether or not we should go in that direction. And medical insurance, 100 million people have, I think 50 million people had no medical health insurance, but 100 million had no dental insurance. And Medicaid covered some children up to the age of 18, but there was no guarantee that any of the dentists were going to accept that insurance. So what I wanted to share with you was part of that story that I found relevant to what we're discussing here, the very point that you're making. So if you could turn to your screens, I'd love to share it. Any moment now. And we just need the sound up.
After 5 years of not being able to afford insurance, his teeth were disintegrating.
He was missing some teeth. He had pain in the front area. He had a lot of broken down and discolored fillings.
I was afraid to floss, afraid that, like, oh my gosh, if I do, like, one of my teeth could fall out.
One team of Harvard researchers asked Americans across the country what their first priority would be if the U.S. had universal health care. Their most common answer? Their teeth. And those researchers told CBS News that a lot of Americans are taking their teeth into their own hands, literally, with pliers.
The easier stories were some of the older men I interviewed who had toolkits. You know, maybe men who had worked in construction when they were younger, so they could use pliers to pull out their own teeth.
Dr. Susan Surratt says lack of basic dental care is creating a second class of Americans, disfigured by rotting and missing teeth.
And if they lose their job, they're going to lose their health care coverage. Lose their health care coverage, they can't take care of their health. Can't take care of their health deteriorates. Their health deteriorates, they become less employable.
She calls it the death spiral.
The death spiral. Patrick Conroy, right up your alley.
I don't know if I like that lead in.
Well, I mean, a lot of people are looking to get their health care and health aid through the services that you provide. So when health services out there that should be helping them aren't, I mean, what do? How do you get the word out that you are being innovative in your approach?
So I think of a couple thoughts. First, CMS, Medicare, Medicaid, and CHIP currently insure about 105 million Americans. With the marketplaces coming online in October, we'll expand that number even farther. In terms of prevention, which we're discussing today, I think we've made a lot of large steps in the last couple years. We now cover all the U.S. Preventive Services Task Force recommendations for Medicare, and once marketplaces coming online, it will also be for those in the healthcare exchanges. So these are breast cancer screening, colon cancer screening, evidence-based prevention interventions, and with no cost sharing. We've had large uptake in that. Two, I think in the broader population health and prevention construct, with our quality measurement programs and our payment programs, we're trying to incentivize prevention and coordination of care. And then lastly, in terms of the innovation center work, we have a number of models trying to redesign care delivery, and many of those, Million Hearts and many others, focus on population health and how we improve the health of populations.
So when it comes to some of those unmet health needs, I mean, how should government work with the private sector to ensure that those basic needs are met?
So I think we're trying to do that in a number of ways. One, for example, we have a state innovation models where we're directly working with 25 states, trying to make sure they work with them to have a set of services, including the private payers and the employers in those states, a set of services to provide the care that their population needs.
And how do you get the word out to your clients?
So I think we try to do that through a number of channels. So I think one, our direct CMS engagement and getting the word out that way. I'd say more broadly, we try to engage with stakeholders who get the word out for us and with us, if you will. So working with states, working with communities, working with our federal government colleagues,
with universities?
Working with universities, provider organizations, research organizations. I think one of physicians and clinicians in the field, and directly with patients and families. I think it's not a single strategy. It's really leveraging and working with stakeholders in the field.
The universities are on the forefront often, certainly in large urban areas and even in some rural areas, of having to focus their resources and in serving those communities. And that's where those communities receive their help.
That's right. And
To get back to the dental question again, I used to do that about 30 years ago, so I thought I'd just chime in a little bit. There's a real disconnect in terms of the public's perception of oral health, for example, and general health. And I'll give an anecdote. We had former Congressman Patrick Kennedy come out to our university several months ago to talk about this new program, the Best Center, that was looking at violence prevention and looking at ways to reduce violent behavior and identify mental illness. And he made a wonderful statement. He says, if you're walking down the street and you see somebody lying there and it looks like they've had a heart attack, what do? You call 911, he said. They show up, they put you in an ambulance, they take you to a hospital, somebody pays the bill, and everybody cheers because we're really taking advantage of the great medical technology and care that we've developed in this country over the years. But if you're walking down the street and somebody's lying there and they're mumbling, what do? Most people, he said, walks around them because they don't know what to do. And I would say the same thing about oral health. He said the mind is connected to the body, folks, and I'm saying that the mouth is also connected to the body. So part of the problem is that we're not looking at this in a holistic way, and we tend to segment the financing, the care, the providers in silos, and we're not looking at it in terms of what's in the best interest of the patient. I would also say that if you look at dental services, patients who are insured, which is, as you mentioned, is only half the population, patients who are insured for dental care, when they turn 65 or 68, whenever they do that, there are no dental services, or relatively few in Medicare, and Medicaid is poorly funded. So you go through a lifetime, for those who have insurance, I'm not even talking about the ones who don't, those who have insurance go through a lifetime of building up their dentition, and then they lose it over the last 20 years of their life because they can't pay for the services. So that's the disconnect that we're talking about.
I mean, is there also that assumption that by the age of 65 they aren't supposed to have any teeth anymore? I mean, I'm just being real here. I mean,
actually, Michelle, everyone has had their focus, I think, and rightly so, for many, many years on children, and children not getting the appropriate care. But we have what has been nicely termed the silver tsunami coming. It's already here if you want to even take it a step further. We're living longer. People are retaining their teeth because they had access to care through insurance, which is usually a limited benefit. It's only a couple $1,000s, but they get to keep their teeth. People are using fluoridated toothpaste. They're doing all the things that we want them to do, fluoride in the water. So now we're dealing with people who are living longer, taking medications, having dry mouth, and getting all the same problems that kids were getting that we're addressing as well. And so that's going to be a huge burden on the economy in this country going forward.
But also, aren't your teeth connected in more ways than one to your heart and to your autoimmune system? I mean, there's research out there that shows that it's all affected if you aren't taking care of this.
Michelle, if I could jump in here, because one of the threads that is throughout the comments that we've already heard is that there's a lot of innovation and change going on in how care is delivered, whether that care is through the public health departments and public health population services or more traditional medical care services. But for the ability of programs like Dr. Frieden's or Dr. Conway's to be able to do this innovation and address the needs that have been described, first, we need to know what those needs are, and that's where health services research also comes in documenting the disparities, the lack of access, the outcomes for populations and for communities. And then the other part is why do we have the U.S. Preventive Services Task Force? Because we do systematic reviews of the evidence. We have to connect the biomedical research enterprise all the way through to the reliable, consistent delivery of care to people who need it. Because in this country, too often, geography is destiny. Where you live, what your social context is, will determine whether you will ever benefit from the innovation and progress that we've seen because of research in this country. And so health services research is part of that connection. You know, there's this term that's used in research of T1, T2, T3, T4. What does that mean? Well, we talk about the translational blocks, how we have to go from bench to bedside, from bedside to community, from community to population health and policy. Patrick, you know, using quality measures to incentivize that certain services get provided and others don't. We have to address healthcare costs. We have to realign our payment systems with rewarding best outcomes, best quality. How do we do that? Based on research that tells us how to measure healthcare, what is good quality, and based on economic research about behavioral incentives. If we don't have all of those pieces of research at our disposal, we're not going to benefit from cures that we're discovering today.
Lisa, aren't we also suffering from somewhat of a brain drain? Who are the researchers? And what was interesting was that I was reading an article not too long ago about sort of the oversimplification of science. And I don't want to call anyone out, but a certain actor who's doing some amazing work at Stony Brook College, Stony Brook University, in trying to have straight talk about science and making it more palatable, acceptable, more part of the mainstream of what their conversation and their semantics is. You say...
Well, the thing about science and all of us, all the different parts of this ecosystem that Dr. Hamburg referred to in terms of the research enterprise, what unites us is our emphasis on scientific principles, on rigor, on really a peer review, that we can really get as close to discovering and understanding disease mechanisms, healthcare mechanisms, et cetera. So that is what science is. And I think what's important in our national discourse is to not pit one type of science against another type of science. For us to benefit, for our health and our healthcare to actually catch up, and this is sometimes not politically palatable, but to catch up with some other countries. If you saw the Institute of Medicine's report on shorter lives, poorer health, for all the innovation, for all the resources we do have, we do not deliver what we could. And so I think we need to really commit to working together to have all this type of research supported adequately, because or else it will only get worse.
How do you see, I mean, I'm looking at our two government employees here. I'm curious, how do you see this sort of divide in America in terms of the haves and the have-nots, and this incredible entity that we call our medical system, and how you have on one hand this everything at your disposal for some, and literally quite nothing for others, or at least people squeezed in the middle, certainly, who are bowing out of their own health care because they can't make ends meet.
Well, I think to start, with the Affordable Care Act, you're going to have tens of millions of people who have access to health insurance and health care who didn't have it before. That's a big deal. You're also going to have no co-payments for preventive services, as Patrick mentioned. That's a big deal. You're also going to have a number of innovations in the center that Patrick leads and elsewhere in the system to move prevention forward. But one of the things that really does concern me is the lack of consistent investment in prevention. And I'll give you an example of this. NIH researchers who were honored last night, well worth it, at the Pharma, came up with the human papillomavirus vaccine. The FDA promptly licensed it. Congress actually authorized payment so that a program that we run at CDC, the Vaccines for Children program, which provides about half of all the vaccines in the country, has eliminated disparities in vaccination rates in kids. And yet, years after licensure of the vaccine, years after it's been recommended, years after all professional societies have recommended it, we're at 32% vaccination rate for girls in this country. Rwanda is at 85%. If we were at 85%, if you take the number of girls in America aged 0 to 12 who should get this vaccine, If we don't increase our rate, 50,000 of them will develop cervical cancer over the course of their lifetime. And for every year we delay, 4,400 more girls in the course of their lifetime will develop cervical cancer. Now, that's a translation gap. That's a different kind of translation gap. That's a gap between what we know we need to do and what we actually do. And the fact that we've had to deal with sequestration makes it that much more difficult.
Question.
You know, that our threats to health are not coming down by 5% per year. Our opportunities to make progress are not coming down by 5% a year. So from my standpoint as CDC director, where our role is to work 24/7 to protect Americans from threats, I have to say, well, for every bit we're not able to invest, we're less able to protect people. There will be more cases of cervical cancer. Now, I think just to get back to your question, we can talk more about sequestration, but to get back to your question about the haves and have-nots, I would emphasize the areas in which we really need to improve the quality of care for everyone.
And innovate.
And innovate. And one of the things that CDC and CMS have done together, and we have had a great partnership on many areas, in fact, I think far different and better than ever before. We're jointly managing projects, we're jointly coming up with priorities, we're looking at what works together, we're figuring out how each other's systems work. One of the things we've done is to launch the Million Hearts campaign. We think we can prevent 1 million heart attacks and strokes over 5 years, and do that by healthier people and better care. And just to focus for a minute on the better care, we know from CDC studies that are rigorously done that only 47% of Americans with high blood pressure have it under control. And actually, if you look at people who are insured, it's not much higher. So we need as a necessary condition to get people insured, but also the new things that are trying to get us more value for our health care, a higher health return on our health investment. And we're finding parts of the healthcare system, parts of the country, providers, small and large, in different systems that are getting to 70, 80, 85% control as opposed to 40 or 50% control, and learning the lessons from those programs and then figuring out how to turn that into policy, how to turn it into best practices, how to make sure that everyone can benefit from that kind of innovation.
Dr. Gershon, you wanted to jump in on that?
I did, an expansion of the prevention conversation. The country spends about $2.7 trillion a year on health services, and about 800 billion of that is for obesity-related diseases, similar to what was discussed, high blood pressure, heart disease, stroke, diabetes, go down the whole list. So the whole notion of behavioral research is really important. Yet if you look at the entire and if you're talking about really making a cost saving and impacting people before the diseases are onset, if you look at the total R&D budget at $144 billion for the country, half of that is for defense and the other half about is non-defense discretionary, and about half of that, a little less than half of that, is the NIH. So when you start, you know, the total amount is 3.8%, but when you get down to it, there's very little for public health related, behavioral related, things that impact us in a big way. And of course we want to have treatments and research on treatments that are going to you know, help us when we're sick. Of course we want to have diagnostics to identify these conditions. But we also want to have people change their behavior so that perhaps we'll have less of all that and we're able to, number one, afford the care we have and also have healthier lives for people. So prevention, behavioral research is another focus. I completely agree with the comments before about the health services research. You know, you got between Medicare and Medicaid a little less than $1 trillion spent out of a $3.8 trillion budget, and yet we're not spending enough money. We spend some, but not enough on how those services are accessed, the costs, the quality, how you put this together in terms of looking at the outcomes. So we're going to spend $1 trillion in the Affordable Care Act, and yet we're not evaluating adequately whether it's going to be effective or not.
Well, isn't that part of the research methodology? I mean, we know, we research things to find out if they work, and we document what happens based on that research. Don't we know what works, what doesn't, and why aren't we funding those things?
So we do for some questions. So for example, obesity was mentioned, but there's several other conditions where a field of health services research is documented the volume-outcome relationship. mainly, the most common are for surgical procedures. So we know that the more that a center and an individual surgeon does a procedure, the better the outcome. So it varies by condition, and there's nuances like all fields of science. And now the marketplace picks that up, and you see folks like Walmart, contracting with centers of excellence. So that kind of information about what works about not just the clinical effectiveness, but how do you organize and deliver care to populations is what health services research is. You ask, isn't that being funded? Well, yes, but it is being funded by the NIH, by the Agency for Healthcare Research, and CMS and CDC, the National Center for Health Statistics, gives us wonderful national surveys and data sets to do this research with. But you were talking about dollars invested in research. Even if you add up all those public investments in health services research, it's less than $1.5 billion. So what are the healthcare costs that we're spending? I won't even, give you the latest numbers. It's a very small proportion of what we're spending, not just through Medicare and Medicaid, but the private sector. I mean, I spent 4 years, I'm a pediatrician at Cincinnati Children's. The innovation that's happening in delivery systems throughout this country to try to get the right care to the right patient at the right time, surgical site infections, central line associated bloodstream infections. We used to have these assumptions about a certain rate of complications being inevitable. Now we know they are preventable. And that's the kind of research we need to keep pushing the limits of how good care can truly be.
Go ahead, doctor.
I was just going to say, so I think, this is about how to refocus our attention. And some of my colleagues are here who run academic health centers in the country. We have 130 academic health centers in the country, a crown jewel of the nation, producing great physicians, nurses, dentists, other health professionals, the whole research portfolio. That's really great. But what do we do with regard to health and wellness? Disease is fine, and the NIH has done a great job on the basic side, and we're trying to do applied clinical research. But what are we doing in terms of health and wellness? And what is our responsibility as universities who focus on academic health issues? What are we doing to train our faculties, train our students, bring the public in so they can really understand what health and wellness is all about? I don't think it's enough to call people up a month before an election and say, oh, by the way, we need some more money, everybody will vote the right way. It's not going to work. What we need to do is educate the public as they're growing up. So more and more universities are looking at having STEM schools on their campuses, having young kids on the campus who can go into laboratories, observe what the scientists are doing, go back home, tell mom and dad, have mom and dad come out and see it on the weekend or whatever, and then as they grow, they develop these as intrinsic values that are important to them. And then when they're asked, when they have to vote, you don't have to convince them. They were there. They know about it. We're not doing enough of that. We're not taking advantage beyond the initial mission of academic health centers.
But there is a flip side to it, isn't there?
Well, this is all great, and I think, kind of sitting here listening to it from and my background, I was a practicing dentist, I was an academic, now I'm in corporate, I've kind of seen—
We wear a lot of hats, don't we?
A lot of different, a lot of hats is right. And what I see is that there's a real opportunity for all of these groups to get together and work together more efficiently and effectively. I think we've got some wonderful examples of things working on a small scale, but I think there's opportunities to kind of magnify that. So just if I could just give you an example, and this is an example that I was involved with, we worked with Columbia University Dental School. They wanted to go into the community and demonstrate that a dentist or a hygienist in a dental office could effectively screen for diabetes in the population. And they had people coming into those clinics, and they wanted to demonstrate, could there be a questionnaire that kind of focuses on specific attributes, characteristics of someone who may have diabetes or prediabetes, and then do a chair-side HbA1c test, which is available today to do, and see what can be the outcome, and then drive them to care. And what they found was, sure enough, they were actually detecting more diabetes coming into the clinical practice of these dentists that they were working with than the statistics were showing should be in the community. So it was actually a higher level. And so this, to me, is an ideal opportunity, especially if you catch someone who's got prediabetes, to get them into diet control and proper nutrition and medication and everything to then avoid all the costs that come with developing diabetes later, which then tax the system, which is part of what Jay was talking about.
There are actually people out there, though, who are fighting Dr. Conroy and Dr. Frieden on many issues with regard to, people being educated more on prevention and methodology and behavior. It's a slippery slope. Don't get involved. Big Brother's coming down. I mean, I open this up to you, Dr. Conway. Forgive me,
Sorry.
Dr. Conway.
I'll answer to whatever.
Please do. Please do. But we look at it from, oftentimes, we aren't looking at it from two different points of view.
Yeah, so let me talk to the consumer engagement piece and that piece, as well as some of the scale and spread. So on the engagement piece and how we engage consumers in decision making, I think it's critical. It's not in a big brother mechanism. It's literally informing with information. I think it was alluded to before on health services research. We have a number of models, for example, right now with shared decision making, and some really growing evidence on shared decision making with patients and families, better health outcomes and lower costs. So we're trying to think, how do you scale and spread those models? To give you a couple other, because I think the scale and spread is the key. I also was at Cincinnati Children's at one point and was a health services researcher at one point in my life. I don't think I count anymore.
No, we still blame you.
But we could improve health outcomes for the whole population in our area, have better health care. We could shift measures, evidence-based measures, from 2% uptake to 100% uptake within 45 days, and we could lower costs for our system. The question is, how do you scale and spread? Just to give you a couple examples that I think are promising. One, line infections was mentioned. We aligned payment incentives, research, quality measurement down 40%, healthcare, bloodstream infection in this country. I distinctly remember as an intern, a neonate that passed away, and we told the family these things just happen. That does not happen in America right now. I still practice. I practice this weekend. We know those things don't happen. Readmissions in this country, we took a lot of heat for readmission incentives and quality improvement. I've got a control chart on my wall, 19 to 20% for decades in the Medicare population, now below 18%. That's over 100,000 Medicare beneficiaries every year staying home and healthy instead of being in the hospital. Once again, payment incentives, research on what works, and investing in communities in the field, working with communities to decrease readmissions. Last one I'll name on the payment incentive, we're investing in accountable care organizations. Our Pioneer ACO program after the first year beat any benchmark quality performance on 19 out of 19 quality measures. So terrific quality results. Growth rate was 0.3%. If this country's national health expenditures grew at 0.3%, we would be in a much better place. So the question is, how do you test these interventions? How do you prove which ones are successful? And then how do you scale them and spread them nationally?
Dr. Frieden?
Well, I think you've raised the question of what's the appropriate role of government. And I think one of the key questions is, what is a unique public good? What is not going to happen if the government doesn't do it? And that includes some research, although there's a very important role for the private sector, for industry, for philanthropy, but some things have to be done by government. It also includes information. We can ensure that there's honest information, whether that's package inserts or accurate marketing of drugs and pharmaceuticals, or menu labeling that gives you the calorie counts, but basic information so that people can make informed decisions. There are also things that we as a government can do collectively, as a society that we can do that we can't do as individuals. So, you might try to put fluoride drops in every glass of water you drink, but it'd be a whole lot easier if we do that at the plant and put them in so you have fluoride automatically. You don't have to go out of your way to do the healthy thing. And the third area is where we want to protect people from something that is not within their power. And that might be from a drunk driver who might run you down or run your kid down on the way to school. That might also be products that are, or components that are in our food that are making us sick that we didn't choose to have there, something like artificial trans fat. So there are many roles for government which are uniquely government. And ultimately what we want to do is increase choice. We want to increase people's opportunities to do things. We want to make it so that if you go with the flow in America today, you will end up healthy. Right now, if you go with the flow in America today, 2/3 of adults end up overweight or obese. 1 in 5 adults smokes. So we have a lot of change that we need to make to support people's choices so that the healthy choice is the default choice.
That's so interesting, because I was going to ask, my last question was going to be, at the rate we're going, and this is to everyone, at the rate we're going, if we aren't more innovative, in 50 years we will be blank.
Sick and broke.
Sicker.
Is that too is that oversimplification too much for you, Dr.
No.
Simpson?
You wanted straight talk.
Yeah, straight talk, right?
I'll give a more optimist. So I think that's certainly possible, but I'll give an alternative hypothesis. I think the cost growth in this country is leveled out. We can do it as part of its economy, but even our own CMS actuaries, who are conservative folk, say that there's fundamental delivery system change happening at some level. So I think there's a chance.
Do all of you agree on that?
There is a pathway to better health quality, better care, and lower cost. I can't.
Yeah, I would add, and we haven't really touched on this yet, and that's the healthcare workforce. So who's going to deliver all these services, whether it be preventive services and so forth? And if you look at the workforce, where people are incentivized to practice, whether they be physicians and nurses or any kind of healthcare provider, pharmacists, they usually wind up in middle class and upper middle class neighborhoods. We need to do a better job in incentivizing people into rural and urban underserved communities and focus more on health disparities. And if we don't do that, we're only fooling ourselves. So where is the research, not just on the number of primary care physicians, for example, but also on the distribution of those physicians, also on the diversity of the workforce? We know that patients will seek out providers that look like themselves. And yet, if you look at underrepresented minorities, it's less than 10% of the workforce. And yet we're approaching 50% of the population. So we need to pay some attention to this. I think we're making some progress. I know that academic health centers around the country are putting a lot of focus on this, but a lot more effort has to be in that area, and we have to measure it. We're not measuring primary care research. How does that relate to the medical home? How does that relate to interprofessional education, working in teams? How we take care of people in a holistic way, and not just in the silos of the specialty?
I'm fundamentally optimistic. I think 50 years from now, there are many positive trends that we're going to expand on. We're going to be reorienting our system to health care rather than disease care. We're going to be expanding preventive measures. We're going to be applying new discoveries that help people live longer, healthier, more productive lives with lower healthcare costs. We're going to be collaborating more between community entities, public health, and health care, so it's more of a health enterprise than individual programs. And even within the healthcare field, I think there's only one solution to the challenge of how do you continue to control costs, extend access, improve quality, and support a vibrant economy. And that's increasing the team-based delivery of care, having every member of the team practice at the top of their license, whether that's dental hygienists or nurse practitioners, physician assistants, nurses, community outreach workers, community volunteers, and making sure that what we have really is making optimal use of all of the wonderful resources which we have available to us, but focusing and holding ourselves accountable for outcomes. That, I think, is the crux of the issue. We need to look at the information and be willing to say objectively and sometimes painfully, this program is working or not working, we're getting healthier or not, it's worth the investment, or we need to change it. Not as an excuse to cut back on services, but as a facilitating way of making sure that the scarce dollars that we have are applied as effectively as possible.
Dr. Foti?
I'm the optimistic dentist on the panel, I guess. So, yes, I am optimistic, and as a parent with 3 children, I want to maintain that optimism because I hope that they have a much better situation health-wise than what we have currently today available to us, which is still the greatest system in the world. I think we shouldn't forget that. I think there's a real opportunity, as I mentioned earlier, for companies large and small to really help with this. And I go back to a recent visit that I made to the National Institute of Dental and Craniofacial Research, which is one of the smaller institutes within NIH, but also a very influential one within dental and craniofacial research. And I met some of the young researchers there, some of these young dentists who have gone not into practice, because there are a few that do other things than practice, and they actually are there getting trained, and they're going to go back to universities, and they're going to go back to give to what we heard about on the previous panel, and kind of giving back to what everyone has given them as an opportunity. And as a company, I got excited about that, and I said, well, what can I do to help? What can we do to help? And through the foundation, we're looking at providing some support. It's not a lot. We're not like a pharmaceutical company that has maybe a larger ability to give, but we're going to give what we can. And I think all companies need to start to think that way, both in the consumer products arena that I'm in, as well as in the other arenas where we're delivering products that are trying to make things better for people. So to me, I'm optimistic that things are going to get better.
Dr. Simpson.
Well, despite my earlier comment, I am also cautiously optimistic, I would say, because I'll go back to the often misquoted thing of wherever it's from, of crisis as opportunity. I actually think that the confluence of the budget situation and the innovation that we're seeing is an opportunity for doing some radical changes that have been needed for a while in how we address health and healthcare in this country, because we cannot stay on the same trajectory. So I'm hopeful that growing understanding of the disparities, of the variations in quality, and yet of the potential for superb care and superb outcomes is there, and that we will get in that direction soon. But we have to make sure that we're all in the same tent for that. And I'll turn back to Congressman Porter's comment earlier about, like, let's get a conversation moving forward with everybody together. And I think that applies in science as well as our larger political environment.
Well, back to Dr. Frieden, forget the 50 years. Let's talk the 50 days. I mean, what do you see in terms of sequestration and what you do?
I'm less optimistic about the next 50 days in terms of the budget. But I guess you just have to come back to the fact that there actually is a great deal that there's consensus on about what needs to get done. There's even consensus on how it needs to get done. There's just not so much consensus on how to pay for it. So I think from the standpoint of science and public health, what we can do is emphasize the return on investment of what we can do. We can emphasize the impact of our actions, not only in this country, but around the world. You know, sadly, because of sequestration, we had to cut back our purchase, for example, of polio vaccine by 40 million doses. Now, there is already a large gap in polio vaccination globally, but I'm confident that we are going to get over the finish line. And we'll get over the finish line because there is a global collaboration, because we have good technology, because we have good monitoring systems, because we're able to say that with an ambitious, achievable, measurable goal, which in this case, disease eradication is the ultimate in both equity and sustainability, because it's for everyone and forever, that we'll get there. And I think that's also the case with things like improving oral health, improving heart health, preventing heart attacks and strokes, reducing the burden of cancer. So to the extent that we can identify specific areas, we can make progress, develop coalitions, go at it creatively, use information not only to set targets, but to iteratively monitor whether we're achieving those targets and improve our programs, we're going to make progress.
Now I'll turn it out to the audience. Any questions? And is there a mic? Perfect.
Dr. Frieden, you mentioned preventive vaccines and diabetes. To what extent is the CDC using social media to take your message directly to the under 24, and how has that changed in the last few years?
Social media is a new world out there, and we're quite active on Facebook, Twitter. We have over 1 million followers on our emergency Twitter account. We've used blogs. We had our Tips from Former Smokers campaign, which was the first ever nationally paid campaign to reduce tobacco use, had a very major social media component. We had 2.5 million downloads of the most hardest hitting ad, So I think this is definitely an area to go. With diabetes specifically, we've worked with one of the cable companies to try delivering the diabetes prevention program that NIH determined was effective, and that we've worked with the Y and others to deliver in the community, and we're seeing if it's possible to do that, you know, over the television. So I think there are a lot of new ways that social media will help us, both in getting information. We've published this week information on the impact of the Tips from Former Smoker campaign that was based on web surveys, because sometimes web surveys may be more accurate than phone surveys and may be less expensive as well. So I think there are important roles for social media. We can't assume that they're going to take care of everything, but we need to figure out the exact or the optimal roles for them in various different efforts.
So, Dr. Frieden, we actually had lunch on Tuesday over at the Press Club, where one of the things you talked about was the 46,000 jobs lost at state and local public health departments, and that's totally separate and aside from what's already happened to your budget at the CDC with sequestration and the cuts that came before sequestration. Can you talk a little bit about that here and the troubles and concerns? I mean, we've talked about tooth decay, diabetes, heart disease, stroke. I mean, there's a lot of challenges out there. Can we address those challenges without those 46,000 state and local jobs, or is that something that concerns you?
Well, we're quite concerned about what's happened at the state and local level. As you say, 46,000 jobs were eliminated because of state and local budget cuts from health departments around the country. With sequestration, we've had to reduce funding that will probably cost about another couple thousand jobs to state and local health departments. And that means outbreaks that will go undetected, preventive measures that will not go applied, people who will not get vaccinated, and diseases that will happen that didn't have to happen. Of course, that will have costs economically, but more importantly, it will have costs in terms of human suffering and life. So I think one of our challenges as we move forward is to emphasize the impact from efforts and the importance of investing in public health at all levels and with all players, including private sector, academia, state and local government, the federal government, and coming up with some ways to preserve the core services that we need to keep us all safe.
Hi, so I understand that some policymakers have asserted that biomedical research is of a higher priority than health and social science research. And as an epidemiologist and as a citizen, how do we convince policymakers that both types of research are really important?
Well, great question, and yes, that is, I'm saddened to say, a conversation that has been heard here in Washington in recent months. And I think that part of it is, I'll take some ownership for that. As fields, we have not communicated as effectively about the science that health services research, social science, et cetera, health economics research produces. And I think we have a communication and educational opportunity, I'm the optimist here, to really help folks understand that you need this kind of science as much as bench science to improve health and healthcare. So I think for communication, that's important. The other one is the partnerships and collaborations and coalitions. Research America brings all of us together in a big tent for science. And I think that kind of work together is also really important, so we speak with one voice.
So my question is for Dr. Gershon. You had said earlier towards the beginning of the panel about how we're still siloed when it comes to oral health, public health, healthcare itself. And I was wondering if you might have given some thought to how we might pay to not have ourselves siloed. So is there a global payment option that you're thinking in your mind that we should be thinking about or investigating, or how might we decrease some of those silos?
Yeah, that's a great question, and I think if we had the answer to that, we might solve a lot of the problems that we have. But I would say that some of that is related to how we practice. And I will say that I'll just give the example of NeoMed. We have a very strong focus on interprofessional education. So our pharmacists and our physicians as students take classes together. They go out on rounds together and so forth. And I think that that's important because people will begin to see the value of the team versus the individual. And as soon as you see the value of the team and how that impacts healthcare services, we can then start thinking about mechanisms for how you get reimbursed for that. Also, you know, if you look at the behavioral side, how much do providers get for spending time talking with their patients about their obesity issue? You know, the payments tend to be skewed towards procedures and so forth. So I will say that that is something that will emerge over time. I think that one thing that the Affordable Care Act will do in a very positive way is to get us thinking that way, because as hospitals think about how to be more cost effective and providers think about how to be more cost effective, they will begin to look at the payment mechanisms.
We have any more questions? Right over here.
Hi, Susan Denser from the Research America Board. Tom, to build on your lack of optimism about the next 50 days, what odds do you assign to the Prevention and Public Health Fund surviving the next round of budget cutting, number one? And number two, we all know that a persistent issue has been the way CBO scores any prevention investments as not producing a return within the 10-year budget window. Do you feel that you're making any headway on that? And is there any hope of resurrecting, for example, the efforts that you have contemplated to roll out a version of the diabetes prevention program, which we know research that showed positive results, which would cost pennies on the dollar to roll out nationwide, produce a huge multi-billion-dollar return on investment over about 30 years? Do you feel you're making any headway in making those arguments in a budgetary context on the Hill?
So to take those three questions one at a time, but briefly, because I think we're just about out of time, I'm optimistic about the Prevention Fund. I think when you look at what it actually does, it has very widespread support. It increases the information we have about health in this country. It helps state and local governments respond to threats. It was essential to response to the fungal meningitis outbreak. The staff who worked on that were largely funded by the Prevention and Public Health Fund of the ACA. And it does things that promote health, including the Tips from Former Smokers campaign, which was funded by the Prevention Fund. So I think we're beginning to see now a recognition that there's a real payoff to prevention. I think that will help it survive in the long term. In terms of the CBO scoring, we have seen some progress. CBO looked at tobacco tax of 50 cents, and the president, of course, has proposed a 94-cent tobacco tax that would protect hundreds of thousands of kids, reduce smoking, reduce adult smoking by more than 2 million smokers. But the CBO actually used a 50-year time frame to look at that. So that was encouraging. They haven't done that much before. And what they basically said is, we'll do that when the data is good enough to do it. Another case for research in this area and research on costs. We're looking at the diabetes prevention program as another potential example of that, which long-term may have a terrific payoff, but may not be visible in that first 10 years as much as we might wish. And actually, we are scaling up the diabetes prevention program through a recognition program where we're recognizing hundreds of providers of it all over the country, and then encouraging insurers to pay for patients to go through the DPP as long as they maintain fidelity to the model that was proven by NIH and validated by CDC studies.
He hit on everything, right? He's just so thorough. All of you are. Any more questions? Well, we'd like to thank our fabulous panel. And as I always stick with first names. Dr. Tom, Dr. Pat, Dr. My goodness, Dr. Foti. And your name tag is even turned around, Dr. Lisa, Dr. J. Thank you so much.
Thanks, Dr. Great to see you.
Thank you. Thank you.
No, I'm just going to thank these people.